So we have quite a number actually joining us remotely, which is exciting, and I'd like to extend a special welcome to those of you who are joining us online. Welcome everyone. My name is Rose Wilcher. I'm with FHI 360 and I co-chair the Gender-Based Violence Task Force with my colleague Kate Gillis from PRV. We work very closely with Mihal Avni and Afifa Abdul Rahman from USAID to co-chair this task force. And it's nice to see, I see some familiar faces and also some new faces in the room, which is very exciting. And for those of you who might not be familiar with the GBV task force, or this is your first event, just so you know, we do host a number of events each year. We try to do maybe one per quarter on different topics and issues related to gender-based violence. I am really excited about our event today because I think there's a really interesting and important story to be told through the event we have today about how you translate global GBV policy into meaningful local policy and practice. And we're really lucky today. We have actually presenters joining us from different points of the globe. We have one presenter joining us from Ireland, and then we have two presenters joining us from Uganda, and then we have one presenter joining us in person here. So everybody's going to keep their fingers crossed that the technology works for us during this event today. And I think we'll have a really fun time. We're going to go through all of the presentations, and then we'll have plenty of time for discussion at the end. But just before I hand it over to our first presenter, I mean, I think why I'm so excited about this event today is because I just don't think there's healthy enough appreciation for what it takes to move from global policy or global guidelines or a global programmatic resource and see that it gets translated into country policy or country guidelines, and then that country policy is actually implemented. Moving from global policy to local practice, it requires efforts that are deliberate, that are planned, that are managed, and that are resourced. And it typically involves a diversity of stakeholders. And so through the event today, we're going to have this case study from Uganda where we actually get to hear about how different players came together and worked together in Uganda to translate global GBV policy into practice. So that's all I'm going to say by way of introduction. And we're going to start sort of from the global perspective and then work our way down. And so without further ado, I'm going to introduce our first presenter, who is Avni Amin. And she's joining us from Ireland, although she's typically based in Geneva. She's traveling at the moment, so we're really happy to have her with us. But Dr. Avni Amin is with the World Health Organization, with their Department of Reproductive Health and Research, and she works on issues related to the prevention of gender-based violence and violence against women. So, Avni, I see you're with us. Can we hand it over to Avni?
I'll be advancing Avni's slides for her, so she's going to let me know when she's ready.
I'm ready. Can you hear me?
Beautiful.
Yes.
Okay, perfect. So thank you, Rose and Kate and Mihal, for inviting me to speak here. What I'm going to do is, before Miriam and Maggie speak specifically to the work that was done in Uganda, maybe just provide a little bit of a global context of how we, as WHO, developed the guidelines, what we did in terms of helping translate the guidelines into country-level policies and protocols, and just some flavor, very, very small sort of taste of where things are being implemented outside of Uganda and what are we seeing in terms of, I don't want to say impact because I don't think we're there yet, but just a few snippets of some success stories. So that's going to be the sort of narrative that I will walk us through today. And with that, if I can please ask either Rose or Kate to just move to the next slide, please.
Hang on just a sec. Sorry,
We're getting there.
there we
Okay.
go.
Okay. So just to start with, to give you a sense of what WHO's priorities are in the area of prevention and response to violence against women. Sorry, can you go back? Yeah. It's in we have four priorities. One is around research and evidence building. And here the focus is on highlighting the prevalence and magnitude of violence, its risk factors, consequences, and to build the evidence on effective interventions for prevention and response, and particularly also research in the area of health sector responses to address violence. The second area, which is what we're going to be speaking to today, is in developing guidelines and implementation tools and setting norms and standards, particularly for an effective health response to violence. And the third area, which is also something that I will talk a little bit about today, is in strengthening capacity of country health systems to respond to violence against women. And the fourth is really around leadership and advocacy and strengthening political will to address violence against women through global as well as national advocacy and through partnerships. So next slide, please. So in terms of the political commitment to the health response to violence against women, just to set the scene, we have in the 69th World Health Assembly 2 years ago, or 3 years ago at this point, ministries of health of the 193 member states of WHO endorsing a global plan of action on strengthening the health system's response to violence against women and girls and against children. And this global plan of action really prioritizes four strategic directions. One is around strengthening leadership and political will to make violence against women unacceptable. The second is around strengthening service delivery and capacity building for the health systems, which is basically the core mandate of ministries of health. The third is around prevention and including prioritizing what can be implemented through the health sector, but also then working with other sectors on some of the more multi-sectoral prevention interventions. And the fourth is around data collection, evidence building, including through strengthening health information systems so that they can collect data on the number of cases that present, but also in terms of survey data and making sure that survey data, whether they are demographic and health surveys or other types of health surveys, are collecting data on violence and its health consequences. The next slide, please. So by way of tools, and this is what speaks to our strategic priority two, which is around guidelines and tools and norm setting functions of WHO. Previous slide, please. What we have now is a toolkit which includes the two sets of guidelines. One is for responding to partner violence and sexual violence against women. And the second set of guidelines is around responding to children and adolescents who've been sexually abused. And these two guidelines then are being translated into implementation manual. One implementation manual is for health workers, which prescribes the how to provide health services. And this is known as Healthcare for Women Subjected to Partner Violence or Sexual Violence. And the other how-to manual, which is also derived from the guidelines, is meant for health managers or policymakers. And that one is called Strengthening Health Systems for Women Subjected to Partner Violence or Sexual Violence, a manager for health a manual for health managers. Now, with these two implementation tools, what we are now doing, and we'll be shortly coming out with it, is a in-service training curricula, both in terms of face-to-face training as well as e-learning. And we're going to package this all into what we call a toolkit, which will give instructions on how these tools can be implemented, rolled out, monitored, and evaluated. And this is really learning from our several years of piloting and rolling these tools out. Just to also flag that we have worked with JPIGO and with USAID and PEPFAR in contributing to their quality assurance tool, which is something that's useful in terms of monitoring and evaluating and improving quality of services. And this is very much in line with the guidance that's already in the clinical handbook and the health manager's manual. Next slide, please. So just a small flavor of what is in the clinical handbook. One of the most important elements of care in the clinical handbook is called first line support. It's a WHO recommendation in all settings as probably the minimum amount of care that should be offered to all survivors, even in primary healthcare settings. And we've developed a job aid to help health workers remember this, which is called Lives, which sort of breaks down into listening with empathy, inquiring about needs and concerns of women, offering them validation, making sure that there is a safety assessment and enhancement of their safety, so safety planning component. And the last S is for ensuring linkages to other social services and support services they need. And really the idea behind Lives is to make sure that the way the first line support is delivered is based on what the women articulate as their need, to making sure that their experiences are listened to and validated, to making sure that they help them feel calm and in control, and to explore with women what their options are, and to make sure that their emotional needs, their practical needs are met. And this is really the operationalization of what we call woman-centered care. Next slide. Then there is operational guidance around how to identify and respond to partner violence. And I'm just going to give you a brief sort of sense of what the recommendations are and how these are to be implemented is spelled out in details in the clinical handbook. But just maybe to say that the first thing is the WHO recommends what we call clinical inquiry. We do not recommend universal screening or what is called as routine inquiry in order to identify IPV. And in simple terms, what it is that when women present with certain signs and symptoms, that providers need to have a low threshold for asking women about IPV. That is not asking every woman who walks into the clinic, but based on signs and symptoms. And those signs and symptoms are listed out very clearly in the guidelines. The second step is around offering first line support, as I just previously mentioned in the last slide, making sure that injuries and other presenting conditions are treated. If there are any pre-existing mental health conditions, then those are referred to. And then there is a package which is around psychosocial support and mental health care, where at the first level we recommend basic psychosocial support, which is around stress management and treatment of mild depression and anxiety. But then for those, and usually it is a smaller number of women who need this, is to assess moderate and severe depression and anxiety and to refer them to what we call cognitive behavioral therapy or eye movement desensitization and reprocessing, which is largely for specialized services. It's not to be done at the primary healthcare level, but this is meant for those with trained by providers who are trained. In certain settings, such as antenatal care, and particularly in high to medium income countries, there is also a recommendation to provide brief to medium duration empowerment counseling sessions and advocacy and support interventions, and those are spelled out as well. But these are quite labor intensive, so we don't recommend that everybody, and in low income country settings, these be implemented widely in antenatal care, because most antenatal care settings are not equipped to handle this. Similarly, for high-income country settings, there is also a recommendation for children who are exposed to partner violence between their parents, and to make sure that they are referred for psychotherapeutic sessions, including sessions involving both with the mother and without the mother. Next slide, please. For clinical care for survivors of sexual violence, particularly focusing on the acute post-rape care period, which is within the first 5 days of the incident, it's first-line support, a complete history, which involves recording any the details of the event, injuries, etc. Then within the 72 to 120 hours, it's the emergency contraception, HIV, PEP, and STI prophylaxis, safe abortion as per national law, and then providing written information for dealing with anxiety and stress, and what we call watchful waiting for up to 3 months. Now, the idea is in this case that we ask people to come back after 3 months for follow-up. But if there are symptoms related to anxiety and stress or trauma, they should be asked to come back earlier. And an assessment should be done if they need to be referred to for post-traumatic stress disorder or depression, in which case they have to be then further referred. Next slide, please. Next slide. Oh, sorry, previous slide. Then there are recommendations around training of healthcare providers. And the training recommendations are really around making sure that every provider is trained in the minimum service delivery, which is first-line support and acute post-rape care. And that the in-service training is really focused on when and how to ask the first-line support. And then in the case of post-rape care, in addition to the provision of treatment, also making sure that providers know when and how forensic evidence collection is appropriate. So we are not saying that everybody needs training in forensic evidence collection, but at least they should know when is it appropriate and how is the forensic evidence collection to be done, so that they can be referred to specific units where this can be then managed. The other training that is important is in addressing provider attitudes towards survivors, and then making sure that the training is not just left as a one-off training, but there's continuous supervision, mentoring, and refresher training. And then the guidelines also suggest integrating into undergraduate curricula. And so the in-service training that we are developing will also include some suggestions for how and what components of training should be integrated into pre-service training for doctors, nurses, and midwives. Next slide, please. And finally, in terms of the healthcare policy and provision, the guidelines really say not to necessarily have standalone GBV services, but to integrate it into existing healthcare facilities. And that the countries should have different models for service delivery, and that there is no one size fits all, which simply means that in some settings, it may be okay for countries to have one-stop crisis centers, but in other settings, such as at the primary healthcare level, a one-stop crisis center may not necessarily be the best model, particularly if it's close to the community, if it's likely to cause stigma and discrimination, and if it's not really sustainable in terms of the available resources, both human and financial. So it's the idea is that the priority should be given to integrating this care into existing facilities, and priority should be given to really making sure that this care is provided at the primary healthcare level as close to the community as possible. But maybe in district settings or in tertiary level facilities, it may be appropriate, depending on resources, to have one-stop crisis centers. Next slide. We do not recommend mandatory reporting of partner violence to appropriate authorities. What we say is that healthcare providers should offer to do so if the woman wishes to do so. And there is a lot of discussion around this, primarily because there is no evidence for effectiveness of mandatory reporting, but also because in many cases, in most cases for domestic or partner violence, women do not want their partners to go to jail, but they want other mechanisms of justice. And so those wishes, regardless of what one feels, need to be respected. Next. So our strategy for supporting countries to use our guidelines and to strengthen capacities has been fourfold. The first is just very basic awareness raising workshops amongst policymakers and managers and health workers. And we have done a number of these workshops in all WHO regions, including for Afro, we did one for East Africa in Entebbe, one for Southern Africa in Johannesburg, another one for children and adolescents in Zimbabwe, for 13 countries in East and Southern Africa. There have been workshops in the Caribbean, in our WHO CRO region, as well as in our Cairo office for the Eastern Mediterranean or Middle East countries. Then we have also sort of proactively or upon country request helped countries to adapt the clinical handbook or to use our guidelines to update their own national guidelines and protocols or SOPs for the health response to violence. And in some countries, they've just taken the clinical handbook as is, made some changes, and translated it into local languages. And in others, they've just taken the content, but developed their own or updated their own guidelines or protocols and training materials. We have also used these materials for doing training of trainers, both at the regional level, but also last year we did a global training of trainers with 60 clinicians from 36 countries, so that we could have a pool of available trainers who could then be called upon or deployed to countries and regions to support countries to do this kind of training further. And we've also been monitoring and evaluating some of these trainings in some countries, as well as improvements in what we call service readiness, so systems level readiness to deliver care to survivors. Next slide, please. This is just a schema of how we have rolled out the clinical handbook in some countries. And the process really has been, convening a national stakeholders meeting with Ministry of Health, with other ministries, with key institutions, with UN partners, then forming what we call a core expert group that reviews the content of the guidelines and the clinical handbook and makes suggestions for how to adapt it to the context. And a lot of adaptations have to do with adding, for example, the legal context, the way the law defines GBV, what that means for health provider obligations, terminology, also adapting formulations of drugs, and making sure that, whether it's PEP or STI prophylaxis formulations, they are in line with the national guidelines and protocols. In some cases, the terminology of gender-based violence has been a subject of heavy discussion, or in some countries, intimate partner violence is not acceptable. So those kind of adaptations have been made. And what happens at the end of this sort of adaptation process, which involves the stakeholder meeting and the core group meeting, is a nationally agreed and owned document, which could be either a nationally owned protocol, or a training guideline, or an SO standard operating procedure, which really is something that the Ministry of Health as well as other UN partners kind of co-own, so that everybody is speaking from the same set of national materials in terms of implementing the trainings. Then taking it further, we've also in some cases translated the handbook in different languages. So it's available in Afghanistan, for example, in Dari and Pashto. It's being translated in Pakistan into Urdu, and in many other countries, they're trying to translate it in different languages. And then there is either a training of trainers or a training of healthcare providers, depending on the context. And we usually, in some settings, have done a pre and a post training assessment, and then gone back after the training of healthcare providers 6 months later to do a post 6-month evaluation to see how clinical practices have changed in terms of provider, not just the knowledge and attitudes, but also how providers have been able to implement what they learned, and also to identify some barriers as well as lessons learned from this whole experience. So Uganda, I think, will be one of those case studies, but we've done similar things in other countries as well. Next slide, please. So here are some of the countries that we have supported in different ways. In Botswana, for example, they took our materials and used them to update their training guidelines. In Cambodia, the clinical handbook was actually adapted and translated into local languages. In Namibia, similarly, they took the clinical handbook as is and then made some adaptations, and that was just launched a month ago. Pakistan, similarly, adaptation followed by a launch, and it's now being translated into Urdu. Uganda, you will hear from Miriam and Maggie. And then Uruguay, similarly, it was translated, adapted, and rolled out. Zambia too did the same thing. But then some of the countries have gone beyond that. So in Afghanistan, they translated the clinical handbook into Dari and Pashto, and they used the content of the guidelines to develop their own national GBV treatment protocol, which with the help of USAID and others, they are now rolling out to train 6,000 healthcare providers across all 34 provinces. And they have completed, I think, trainings of at least 4,000 providers in 2 phases, and are working towards the third phase, which will complete the rest of the provinces. Cambodia also has been doing some work and is rolling it out in 11 provinces. And then we are using same materials but adapted for humanitarian settings. So in Bangladesh for the Cox's Bazar, in DRC, in Iraq, Nigeria, and in Syrian Arab Republic in Aleppo. There have been trainings with health cluster actors as well as the health providers providing services in this context. Next slide, please. So just here are some key achievements. I think in Uganda, you will hear a lot more from Maggie and from Miriam, but I think the idea of having a plan for scaling up these services based on the pilot that was done in 3 provinces has been one of the key milestones achieved. In Cambodia, as I said, it's being scaled up in 11 provinces, and there's discussions on how to integrate this into pre-service curricula. And in Afghanistan, as I said, this is being rolled out on scale. Next. So just these are 2 stories from the field. One is a story from Sedovip talking about how a man in his 40s raped a teenage girl and then tried to give bride price to the family as compensation to marry her, but the girl had somebody else she wanted to marry, so she went to the healthcare facility where she had been treated following her rape, and the health worker, I mean, not only did they protect her from the community, but also talk to the community and help them understand that this was not the right thing to do, and that her right to safety should be respected and her right to autonomy should be respected. And eventually the story came back as the community accepted her back and the family allowed her to marry the man she loved. Another story we have from Afghanistan from one of the midwives in the clinics talking about a 27-year-old woman who came with severe injuries and who was in a state of emotional distress. And the provider who had been trained, noticing some of this, including some of the symptoms of insomnia, asked her about violence, and then after doing first-line support and reassuring her about confidentiality, gave her the treatment, referred her for additional counseling, and here they were able to offer her regular counseling and follow-up, which then resulted in over a few weeks noticeable improvement in her mental health. Next. So just to close, what are some of the things we are learning from all these efforts? The first thing is obviously the importance of infrastructure to ensure privacy, patient flow, and other mechanisms. And I'm sharing some pictures of some of the work, for example, in India, where they set up a private room for examination of survivors, then making sure that there are procedures for confidentiality, including, storage cabinets for locking records, etc. The documentation, and in several settings, including Uganda, India, and other settings, facility-based registers have been introduced. IEC job aids have been placed everywhere in clinics, and here again there are some pictures of posters which indicate to the patients coming to the facilities for other services. This is, not necessarily for GBV, but, antenatal care or family planning, that there is a healthcare provider who is trained to provide services or care for GBV, and that they should be able to ask if they are experiencing violence. And it also sends a signal that this is what they should expect from the provider in terms of the kinds of care that they should be expecting. The other element is the importance of strengthening referrals and linkages. And at least in Uganda, in one setting, for example, the facility was able to establish linkages with a local NGO that was just about 100 meters away, located from the clinic, and refer patients needing additional counseling and support to that facility. And then the other lesson we really learned is about having managers who are champions. In both India, Cambodia, and Afghanistan, we really had to work at sensitizing managers, administrators as part of the training, so that they were able to support, supervise, and mentor the clinicians who were trained. The importance of making sure the communities are aware that there is services provided, but also that the importance of seeking care in a timely way. And then the important lesson that we've learned from all of this has been that these processes, not just translating it into national guidelines, but also building support, building a momentum, building a policy sort of readiness in ministries of health and with other stakeholders really takes time. None of this has been overnight. It's work that's sort of been building up over the last 6 to 7 years, and it's only now that we're beginning to see some positive momentum and results that we need to sustain. So I will end with this. Thank you so much.
Great. Thank you so much, Avni. Great presentation. And what I hope everybody took away from that is Avni's really given us a snapshot of, sort of from a global perspective, WHO, the World Health Organization's position on how the health sector can and should be involved in addressing gender-based violence, and some of the tools that they've developed to support that response. But how do we go from, a global policy endorsement and global tools down to meaningful local practice? So that's where we're going next. We're now going to take a deep dive into Uganda and hear about really the process and the experience of moving from, global policy to institutionalizing local policy change and local practice. Because as I think Avni's last slide showed here, you might have really nice policy statement and really, concise tools and resources to use, but it's a really complex process and lots of moving parts. It takes time, but it can be done, as we're going to hear from our colleagues in Uganda. So we have two presenters from Uganda, one from the Ministry of Health and one from the Ministry of Gender. And so we're going to have the opportunity to hear about how they worked together to translate some of this guidance into policy and practice. And then we're going to close with a presentation from our colleague from the HP Plus project, because they had the opportunity to go in and do sort of an objective assessment of the degree to which the GBV policies that Uganda adopted were actually implemented and what effect they had. So I'm now going to turn it over to our Ministry of Health colleague, Miriam Namgere, who is joining us from the office in Uganda. And I think we have Dr. Ibrahim helping with the technology there. And I want to acknowledge that Miriam developed this presentation in collaboration with her local Ugandan WHO colleague, Dr. Olive Sentumbwe Mugisa. Olive isn't able to join us today, so Miriam will be presenting on behalf of both of them. But just to say that Miriam works at Uganda's Ministry of Health, where she coordinates the ministry's GBV and adolescent health programs. And she chairs the National Adolescent and GBV and Male Involvement Working Groups. And she's both a registered nurse and a registered midwife. So we're lucky to have Miriam joining us. Miriam, I'm now going to hand it over to you.
Yes, we are ready.
Great, we can hear you loud and clear.
Okay.
1 second, we're pulling up your slides.
No, so you all should pull up the slides on your end, and you now have control, so you'll be able to advance them yourselves.
Which is better with you.
Build them up from there.
Hmm?
I have the slides.
But why don't we?
No, they are loading the slides.
Why didn't we keep it?
Hold on.
Are you there? Yeah. So we can see
I
your screen.
can't, but
We can see your screen. If you can go ahead and open your slide presentation.
Dr. Ely.
Where can we, excuse me.
Yes, on your computer, if you go ahead and open your slide presentation, we'll be able to see it from here.
Okay, that's great. Today. Slow.
Yeah, it's okay. We see it. We see it coming up.
Okay. Melia is ready for the presentation.
Okay, well, Miriam, you can just proceed from your end. As soon as the slides come up, you go right ahead and you can advance them yourselves. No need to wait for us.
Control F5.
Can you open the slides on full screen?
It's okay.
Okay. Yeah.
Are you okay now?
Can you put
Can
them?
you see?
We can see them. If you could make it, if you could start the slideshow so that it's full screen. There, perfect.
Okay, go ahead, Miriam.
Is it okay?
Yes.
Okay. Good afternoon, everybody. Good morning.
Good morning.
I'm Miriam, presenting on behalf of myself and my colleague, Dr. Olive, who is out of the country. And I'm going to present on strengthening the health system's response to violence against women in Uganda. And I will be sharing the lessons learned from adopting and implementing WHO guidelines and tools. Uganda, like many other countries, still has a high rate of gender-based violence. For instance, 51% of women report having experienced physical violence in their lifetime, whereas 22% report having experienced sexual violence in their lifetime. Much as we all know that the causes of gender-based violence lie in the power imbalances, gender inequality, and human rights abuse, there are other factors that fuel the occurrence of these acts of violence. For instance, attitude. Attitude plays a very big role in the occurrence of these acts of violence, especially when people take the acts as being normal. When you look at those bars, you find that we have, the bars are showing the attitudes of men and women towards domestic violence. And it is clearly shown that, and it has justification given by men and women for violence against women. For instance, people think that if a woman is cooking and the food gets burnt, then she should be punished. And it is surprising that it is mainly the women who think they deserve to be punished if anything goes wrong. Like for the burning of food, 14% of women think the men should punish them for that, compared to the men who think so. Then when you look at the second bar, if you argue with a man, 20% of 26% of the women think that they should be beaten compared to 23%. And as you see the graphs, it goes on. But overall, 49% of women think that they should be punished if they committed any of those acts as indicated. However, this attitude is not stagnant. With the sensitization and the training and the dialogue, there is a decline. In 2001, the overall attitude about violence was higher than the 49 we are seeing. It was at around 77 among women and 41 among men. But with a lot of advocacy and dialogue, we are seeing a change. Some of the activities that we have done in the adoption of the WHO guidelines. First of all, we had a stakeholders engagement, and this brought around representation from line ministries and the government departments, UN bodies, NGOs and civil societies that are engaged in the provision of services to respond to GBV. And we used evidence-based information for these advocacy activities. In 2014, Uganda as a country, we conducted a preparedness readiness study to see how, as a country, are we ready to respond to GBV. This study was done across the sectors, including the key implementing partners. And it showed where we had the strengths and the areas where we had gaps. So we used the results from that preparedness study to advocate so that we can realize the goal of responding effectively. And we used some of the evidence of research done here in Uganda and outside to update the training guidelines in line with the WHO recommendations. We did this through still a multi-sector engagement, and we managed to come up with the job aids for healthcare professionals, and we trained health workers. This helped to improve the knowledge and preparedness among service providers, and right now we promote health response to violence against women across the service points. For example, in family planning, we categorically do clinical screening where there is a suspicion of a mother or a client experiencing violence. We also do clinical screening in HIV. We do clinical screening in antenatal. Actually, we have adopted, or we are integrating violence against women across the board in all our service areas. And we have also adopted the quality improvement tool, which was developed by JAPIGO, WHO, PEPFAR, and the CDC. So we are able to monitor our services, but also we are using this tool to mentor and supervise services. Some of those pictures are showing some workshop during the adaptation of the WHO guidelines. And below, we are going to see the process which we took to adopt the WHO guidelines. First of all, we had a national stakeholder consultation. This one was mainly to build the consensus on the need to update the national training guidelines in line with the WHO clinical guidelines. And this one, after building the consensus and we agreed that we needed it, we had to call the technical working group. We have a technical working group on violence against women and male involvement in the country. So this is the working group which looks into the issues to do with GBV and male involvement in the health sector. So here we came together and we reviewed the existing guidelines and we harmonized it with the WHO recommended guidelines. Thereafter, we had a training of trainers. We trained about 20 trainers who later on conducted training of healthcare providers in the 3 districts that were supported by WHO at that time. That training was also helping us to test the adopted guidelines to see whether they suit our setting. And during the training, we could have the pre questionnaires or pre-test to assess the level of knowledge of the service providers. And then we could also have a post-training questionnaire to find out how much the people have gained in terms of knowledge. Then 6 months later on, after the training, we could have a follow-up to see whether what was achieved in the training is being put in, is being practiced. And that 6 months follow-up also serves as a mentorship training, on job training. That's when you go and you see if they are implementing the new knowledge, and if not, why, then come up with a solution on how to make sure that what is the implementation is according to the standards. After that, after the training, however, we had a workshop of the trainers at the national level to assess the progress, and we had a national action plan on violence against women. Actually, this one also, we are adopting the WHO action plan of action on violence against women and violence against children. We are using that guidance to see how we can fit in as a country to be able to address both violence against women, violence against children, and interpersonal violence. Actually, we are adopting that one, and it is in the final stages. There is still ongoing advocacy with the policymakers. Much as the gender-based violence or violence against women is as old as mankind, it still needs a lot of advocacy if it is going to be accepted as a determinant of health, because the health sector had for long worked without integrating it. So there is still a lot of advocacy. Much as we are proud of successes, we can't do without more advocacy. The adaptation, we made a number of, we adopted a number of guidelines. One is the Uganda National Guideline for healthcare workers on the management of sexual and gender-based violence. This one, actually, the initial document that we had was the WHO clinical management of rape. But we expounded on this during the adaptation to add more information which we thought was needed for the health workers to be able to offer these services comfortably. So we added, it has 6 modules. The first modules gives an overview of gender-based violence globally, but also nationally, using our local data. And then it also, module 2, looks at the law and sexual stroke gender-based violence, because here we felt the health workers needed to know what laws are related to gender-based violence and how can they work within the law, or how can they work to support the survivors get redress. There they needed to understand a bit of the law to be able to offer services in that line. Then communication, module 3, psychosocial and mental health counseling. We also added that one because we believe that the words are the best medicine. The way you talk to these people matters to the survivors. And there is a lot of psychosocial support which is needed, and the mental health counseling. As we all know, at times the forgotten consequence is the psychosocial consequence. But we wanted it to be brought out here and emphasize the need to look at the survivor in a holistic manner. Then module 4 covers the clinical management of GBV survivors. This is the one which deals with the history taking, the forensic evidence management, the prescription of medicines, including PEP, EC, antibiotics, immunizations, as need be according to the survivor's need. It is discussed under this clinical management of GBV survivors. Then module 5 talks about the networking and social mobilization for GBV. We all appreciate that GBV cannot be handled by a single sector, but here we put light on who are the other people who are handling GBV and how we as people in the health sector can work with them. So there is a lot of emphasis here put on the linkages and the referrals for GBV and how to maintain them. And then, of course, for any program, it has to be monitored and evaluated. So we also put a module for health workers, and here we talk about the indicators, the tools that we use, and that kind of information is covered in the monitoring and evaluation. So here in this, we came up with 2 manuals, the trainer's manual, which gives guidance on how that information is delivered, and then the trainee manual with the core content which is to be delivered. And we also came up with contextualized job aids. Actually here, I can say that the WHO IPV guide, we took it on wholesale, we adopted it without changes, because we felt the information there could fit in our context very well. So we didn't make a lot of changes in it. We took it as it was
Miriam.
proposed.
Hi, Miriam.
The picture you can, yes, please.
Miriam, this is Rose. You've got about 2 minutes left, so we're going to need you to speed through these remaining slides a little more quickly, okay?
Okay. Thank you. I'm about to finish.
Okay.
The pictures you see here is during a training, and they are showing the networking, or you can see different people from different sectors. But we carried out trainings, like I had already mentioned, TOT, and then the districts that where we took the training was conducted was those 3 districts, and a total of 45 people was. Then the progress and achievements, we have progressed well, and achievement, we are still recording achievements. In awareness, now most health workers, you go to the facilities and they are aware of GBV as a health issue. And actually what I forgot to say is that even now as a sector, we recognize GBV as a public health issue, and it is part of the minimum health care package. When you go to the facility, there are focal persons for GBV, right from the ministry, that is national level district, but also at the health facility. We have political commitment and policies, and now violence against women, because we take it as a cross-cutting issue, which should be integrated in all other services. And we are getting more donors that are now putting funds into the activities to respond to GBV. Just to give an example, European Union, CIDA, USAID, they are all now supporting GBV on top of WHO, of course, and the UNFPA. And we are registering improvements in service delivery. More survivors are being identified, of course, implementing the clinical screening approach. And also we are more information is given out on violence against women in the antenatal clinics. It is actually now information on health education on violence is in all of those areas where we have integrated GBV, and we have better referrals across other sectors. There are changes in the health work capacity and skills. Now health workers are equipped with skills, and the training showed improvement in knowledge. Actually, when we adopted the quality improvement tool, we have piloted it, and by the way, we are even registering in some facilities where they are scoring 100%, 95, although some others are still doing poorly. We are not moving at the same level. Even the community is becoming more aware of GBV as an issue, and there is consistent and quality support for survivors and families. Although here, maybe Maggie will talk about it, we still have challenges. And
Miriam?
we are having positive.
Hi, I'd like to suggest that you
Yes.
look for the challenges for the discussion. And if you want to jump to your last slide, I think it is about lessons learned, that would be great.
The challenges are many. They are highlighted. They are in the facilities where we have conducted training. There are regular rotation of health workers, and once they go away, then there is lack of privacy in some of the facilities. Supplies is a problem, because as we all know, GBV has specific supplies that are needed, and there is lack of knowledge about the relevant laws, much as we are. Then the lesson is learned is that evidence is needed for advocacy of women being a public health issue, and advocacy necessary at start, and it should be continuous. And the multi-sector holder group for adaptation process is crucial, because there we get inputs from all of the crucial sectors, and the formation of technical working group, like I said, is also very good. It helps to address all of those issues, and we need a dedicated budget line on violence against women at all levels. And it is important to celebrate, share, have meetings, share the achievements. Health worker training, actually piloting and evaluating necessary support scale up, because there then you get information on what worked and what didn't work. Then the job aids, ongoing training, mentorship is very crucial, and health worker rotation is frequent and impacts provider training. Then it impacts actually on the indicators. What are our priorities? Our priorities is to continue training and mentorship for health workers, not only for in-service, but to include a module on violence against women for in-service, for pre-service. Because if now health workers qualified when they have, it will reduce on their expenditure on in-service. We need supplies and resources. Actually, initially we were thinking of having locally assembled resources, but it is also debatable because people were now bringing in issues of quality, and the evidence is crucial. Advocates, like I've already said, it is a continuous process. We need to continue until we achieve, I think, quality services for everybody. I give you a quote from Tina Mushuya, Executive Director, SEDOVIP. She said, preventing and responding to GBV is beneficial for everyone. It improves health outcomes and income, and the well-being of men and women is guaranteed. Thank you.
Great, thank you, Miriam.
Okay, they are finished.
Dr. Ibrahim.
Those three ladies, one name is Dr. Olive, another
Okay, thank you, Miriam.
And
Dr.
last one is Miriam.
Dr. Ibrahim, while you're getting
Yes.
Maggie's slides pulled up, I'm going to go ahead and introduce her. But first,
Okay.
Miriam, I want to thank you for your presentation, and I want to thank you also for your leadership on behalf of the Ugandan government and the Ministry of Health in really moving the needle forward on how the health sector is responding to gender-based violence in Uganda. It looks like it's been quite the effort over the last 4 years. So thank you for that. And I'm looking forward to the discussion that we'll be able to have with you after the presentations. We're now going to jump to our next presenter, who is, sorry. And Dr. Ibrahim, can you close your, what looks maybe like your email inbox or your alerts, because they're showing up on the screen here. Okay.
Sorry, is it?
Yeah, we have there's in the bottom right-hand corner, it looks like a news headline perhaps has popped up.
Just hit close.
Oh, sorry. Sorry.
No, thank you.
I said it. Sorry. Yeah, these are just pops.
Okay. So our next presenter is Maggie Chomukama, who works with Uganda's Ministry of Gender, Labor, and Social Development as the Assistant Commissioner for Gender and Women Affairs, where she is primarily responsible for policy development and programming for gender equality and women's empowerment, including addressing gender-based violence. So Maggie, I hand it over to you.
Yes. Thank you very much, and thank you to everyone. It's a pleasure to join you today. Yeah, so I'm going to focus on the role of the ministry in development of the GBV policy and in the practice. So basically, I'll reflect on what the impact the policy has had and share some of the lessons learned and challenges. So this will be very brief, as you all know, and Miriam had the slide that showed the policy. Our ministry is responsible for policy formulation in the area of gender equality and the empowerment of women, including gender-based violence. And this policy came in after the Uganda gender policy of 2007. And it has made a significant contribution to strengthening the framework for prevention and response to GBV in Uganda. And this is why I say that it has strengthened this, because the policy was informed by various initiatives. So the policy came after already there was programming ongoing to address GBV, and various efforts by different stakeholders were ongoing. But that being the case, there was also extensive stakeholder consultations and engagements at all levels. We already had a good practice in the multi-sectoral coordination. We had a coordination mechanism even before the policy was in place, bringing together the different agencies in government, civil society, and other practitioners at national level, and which we had also decentralized to the subnational level. We had a strong legal framework. We had several laws in place, including the Domestic Violence Act and the law against female genital mutilation. And all these were, and we also had structures. And then, as I had said before, we had many programs ongoing to address this. We had data and information from national surveys. I'll mention that again in the lessons learned, because we had the UDHS that put a model for gender-based violence to give us more evidence nationally on the prevalence of gender-based violence and the types of violence that were occurring nationally. There were also very many researches, and then of course documenting both at program level, at national level, best practices. And then there was increased public awareness and advocacy. For example, the 16 days of activism against gender-based violence used to be more or less a civil society advocacy event every year. But now it was upscaled to a national level where the Ministry of Gender, Labor and Social Development would take a lead, and it took a national perspective. So all those contributed to informing policy. So what have we learned? That first of all, the policy came in because it was government-led. The ministry played a key role in all these, the players that were working on GBV. It had to be a ministry, and it so happened to be the Ministry of Gender, Labor and Social Development. Although the Ministry of Health was doing incredible work, we had the Justice, Law and Order sector, Uganda Police Force, the judiciary, doing a lot of work, but still there had to be a lead agency, which was the ministry. Then there was ownership by all stakeholders within their respective mandates. As Miria has outlined, Ministry of Health took this on and really integrated it within the mandate of the health sector. So that ownership in the different various ministries, departments, agencies was really good. Another lesson we've learned in terms of translating policy into practice is that you still require strong coordination mechanisms. Right now, as we have been having a GBV reference group and subcommittees under that reference group. And last year, we started a high-level policy dialogue, which is chaired by the Honorable Minister, that brings together all the stakeholders, including the donor community, the development partners, UN agencies, civil society, and everybody else at national level, to see how are we implementing this policy, what needs to be done, what are the gaps, challenges, and what's the way forward. And then another lesson we've learned is that you must continue the advocacy, information sharing, because still, as Miriam was saying, there's the attitude, social norm change takes a long time. So continuously, we need to do advocacy to share information, evidence that justifies why this is a priority within government. Another lesson I've learned, as I said before, is that you really need the research and data. And working with the Uganda Bureau of Statistics, making sure that there was a model within the Uganda Demographic and Health Survey. And recently we have had a time use survey and other researches that were undertaken. I think Ministry of Health did one in northern Uganda to look at how the northern Uganda conflict had influenced gender-based violence. That was also really good to have that. We also had recently with UNFPA a specific study in the communities that are practicing female genital mutilation. So the evidence for policy and decision making is really very, very critical. Then as a ministry, with the support of other partners, we have the online database that records the incident data. In other words, the type of incidents that are reported at service points. If you go to police, if you go to a probation and social welfare officer, if you go to a health worker, clinical officer, we have a database, and now we have upscaled it to be online, and that would give us an area specific as opposed to the country and general data we get from the UDHS. Another lesson learned, again, which Miriam talked about, was increased capacity building in all the institutions for service delivery. Service delivery, after raising awareness, we've noticed that communities come up, they expect the services. And we need to have that capacity to respond effectively. So Miria has outlined very well what health has done, but equally so in the Uganda Police, they have a special unit for this, and the capacity is being built. They also have training, also with judicial officers across the board, social workers. Each sector has taken on its role in building the capacity within its respective institution. So we have integrated or mainstreamed GBV prevention and response. But then again, we've learned that we need human and financial resources. This has to be continuous to support the services delivery that is required at the quality that is required also and expected. Yes, so this one again, integrating actions for GBV prevention and response. In other words, if you have to earmark resources, you have to plan for them. And so these actions have to be integrated within the different planning and policy frameworks so that then you can justify their resourcing. And then also male engagement is a key strategy for positive social norm change. And we have highlighted this both in our policy and learning also from the health sector, where they have a male engagement strategy for reproductive health, SRHR. We noted that if you're to change in a patriarchal society like Uganda, you must have that positive social norm change, and men must be at the forefront of this. Young men and at all ages. What are the challenges? Maintaining a strong cohesion through this multi-sector framework is not very easy. Yes, we do have the gender-based violence reference groups, but it varies in terms of participation. So there has to be something that's pulling together, something that brings everybody together, a common understanding, a common drive to achieve through the policy implementation. So that has to, that's what I'm saying, we always strive to change the different forms, to listen, to have a listening ear as the Minister of Gender, Labor and Social Development, hear what our partners are saying, both in terms of practice and in policy formulation, capacity development, resource mobilization, and the like. Another challenge is maintaining the quality of service delivery along the referral pathway. This varies. For example, we have a rural-urban divide. It's much easier for people to access the various services within an urban setting. In rural and hard-to-reach areas, it's more difficult. So we have challenges there. and also the community can create apathy. Yeah, for example, when we say you need to reach a health unit, but how accessible is that health unit? You need to report to police. So that is the type of challenge we have across the board. And then, of course, the limited human and financial resources within the different settings. Yeah, that's it.
Great.
That's it from Maggie.
Okay, thank you so much, Maggie. That was also a really excellent presentation, and nice to hear how you and Miriam have been working together to support a multi-sectoral response to gender-based violence in Uganda. We have one more presentation, and then we're going to open it up for discussion. Miriam and Maggie, stay with us because you're going to be rejoining us for the open discussion part. I'm so glad the technology worked for us for your presentations. So our final presenter is with us here in person. Beth Rotak joined Palladium in 2011 as a gender advisor, where she is responsible for providing technical leadership on global and country health systems and works to strengthen projects related to gender equality and social inclusion, GBV prevention response, and family planning advocacy. And as I mentioned earlier, through the HP Plus project, Beth was involved in an assessment of sort of the extent to which Uganda's GBV policies have actually been implemented. So I'm going to hand it over to Beth. We're going to hear about this assessment, and then we'll open it up for discussion.
Okay, great. Okay, good morning. Thank you for joining us today. So as Rose said, I'm going to be talking about an assessment that we conducted under the Health Policy Plus project. It's a USAID-funded project. And the objectives of the study were to identify GBV-related policies in Uganda and examine how those policies are being implemented. Our assessment focused on the role of the health sector and examined whether the policies and their implementation address the family planning needs of GBV survivors. And this picture here is a picture of our data collection team. So to conduct the assessment, we adapted the policy implementation assessment tool, call it the PIAT. This was a tool that was developed under a prior USAID-funded policy project. And it defines 7 dimensions of policy implementation, such as leadership, stakeholder involvement, resource mobilization, and monitoring. And so this framework and these categories are how we structured our data collection and our analysis. So when we say we were assessing implementation, we were looking at these areas to determine how the policies were being implemented. Our methods, first of all, the study was conducted from June to December 2017, and our assessments included a literature review, policy text analysis, and key informant interviews. So it was largely a qualitative study. And we conducted 70 interviews at the district level. It was 8 districts, and you can see the names and locations on the map here. Okay, so now I'll talk a little bit about what we found. Overall, as we've heard from my colleagues prior, there is a strong GBV policy framework in place in Uganda. We identified 22 national policies or guidelines that address GBV or family planning. So while the previous discussions focused largely on the SGDV clinical guidelines and the health sector guidelines, we looked more broadly at the kind of the country's GBV policy framework. And in this table here are a few examples. It's not all of them, but just a few examples of the policy provisions that the health sector is responsible for implementing. And because we were interested in the health system, we organized it according to the WHO's 6 health system building blocks. So this just gives you an idea of kind of the range of responsibilities that the health sector has in implementing GBV policies and what we were assessing. So we'll look now at the drivers and the gaps for policy implementation. And I think you'll hear a bit of overlap from the previous presentations, and so I might skip ahead through a few just to reduce repetition. First and foremost, of course, there's the comprehensive multi-sectoral framework in place. I think we've discussed that, so I won't spend too much time on that. In addition, there's a very clear and defined role of the health system in GBV prevention and response, in line with international best practice. The health system's primary role is providing post-GBV care services, which also includes provision of emergency contraceptives. So there was less focus on primary prevention, but that role still exists through awareness raising, advocacy, and data collection. The third driver was the effective GBV training for health providers. Again, we heard quite a bit about this curriculum through the prior presentations, but just to reiterate kind of what our colleagues were saying, we heard very positive feedback about this training from the health providers. They said it improved their knowledge and skills in handling GBV cases, taught them how to examine survivors, ensure confidentiality, ask probing questions, and offer family planning. And I have a nice quote, which I think summarizes well, from a health provider. She said that participating in the training enabled her to manage the patient as a real patient and not just a survivor with police issues. On the other hand, the trainings have not reached all health providers in all districts yet. And those individuals that have participated in the training have asked for regular refresher trainings and ongoing mentorship. So they've made a great start, and there's still a lot of work to do to continue to scale up the training and continue to support the health providers. The fourth driver is around multi-sectoral coordination mechanisms. Again, we heard about this in the earlier presentations. We looked at this at the district level and found that there are quarterly GBV coordination meetings that are happening. And during the meetings, which are attended by representatives from the Department of Health, community development, politicians, police, NGOs, they get together to share data, discuss challenges, and make plans around service delivery. And there was an evaluation conducted under the Government of Uganda Irish Aid Joint Program, which was looking at the broader program, but also looked at these coordination meetings. And they found that holding the coordination meetings improved collaboration, which in turn improved service delivery. So this could be a really effective model to scale up to other districts and perhaps even replicate in other countries. And then the last driver are donor resources that align with policy goals. So unfortunately, public funding for GBV remains exceptionally low in Uganda, but donors have stepped in with funding, which is aligned with policy goals, which is great, and enables the district staff to carry out programs that they otherwise wouldn't have the resources to implement. So the main donors are, of course, WHO, UNFPA, USAID, DFID, and Swedish CETA recently launched a new enlarged GBV program as well. Okay. So even with good policies and good training materials, there are still some challenges and gaps. First is that the policy framework is inconsistent regarding provision of emergency contraceptives. Some policies allow for provision within 72 hours and others up to 120 hours. So our respondents didn't actually mention this discrepancy during the interviews, but most providers that we spoke to said that they're providing EC within 72 hours, so that shows that they might be following outdated guidance. There's also inadequate policy and guideline dissemination to districts and health providers. So even though we have this really strong, really nice policy framework in place, there's a gap in the knowledge base of those responsible for implementing it. Many respondents reported being aware of the policies, but were unfamiliar with the details. Hard copies of the policies were generally unavailable in the districts. They're not translated into local languages, and so they're inaccessible to portions of the population. And of course, as I said earlier, not all providers have been trained on the SGBV clinical management guidelines. And those that have been trained said that they weren't able to get copies of the guidelines, which would be a useful resource to help as they begin implementing. Then, of course, there's the low levels of public funding for GBV policy implementation. Programs are just severely under-resourced. There was a study by Sedovet which found that while the Ministry of Health had included GBV-related activities in their annual work plan, the budget didn't allocate funding for most of the activities. And so I think that's one reason that we're seeing donors step in to fund some of these initiatives. And one explanation that respondents gave for the funding gap is the lack of reliable data, which is our fourth gap. So as we know, data plays an important role in budgeting and planning at both the national and the district levels. But the data management systems, while they are improving, still don't provide adequate information on number of GBV cases, or especially provision of post-GBV family planning services. And so without this data, it's difficult to make the case for increased investment or to even plan programs. The fifth barrier or gap is around operational barriers. So while the health providers that we interviewed talked very knowledgeably about the SGBV management guidelines, they said that they're often not able to implement them as they're supposed to because of the lack of contraceptive supplies or other supplies like rape kits or disposable clothing to give to survivors when their clothing needs to be collected for evidence. They found creative ways to work around this. So they redistribute emergency contraceptives or prescribe combined oral contraceptives as EC, or will often refer survivors to private clinics. And then, of course, the final gap is that rigid cultural and gender norms conflict with policy goals. So we heard lots of statements around how communities don't consider violence a problem until severe injuries occur. In some cases, parents, actually in a lot of cases, parents prefer to settle cases informally, and so will invite the perpetrator to come and negotiate, as they said. These weren't uncommon and reflect the inherent conflict between GBV policies and cultural norms. And it's not surprising. I mean, individuals who are responsible for implementing policies are not immune to cultural norms, right? They live in the same societies as all of us. And so unless these norms that condone or normalize violence are addressed as part of policy dissemination and implementation, we're never going to see policies be as effective as they could be. And here's a nice quote, I think, that highlights that tension between cultural norms and policy goals. So I'll just read it aloud. It says, like the cultural aspect of child marriage, the cultural belief of female genital mutilation, all these are cultural aspects which are embraced by the community, but then the policy says we should fight against them, but culture says it's okay. How do we merge cultural aspects with implementing the policy? Okay, so we had just 5 recommendations. First one, of course, is to update the policy recommendations on provision of emergency contraceptives so that they're aligned. Second is to develop GBV policy dissemination tools. Again, I think my colleagues prior talked about the need for job aids and hard copies of the policies in districts in the health facilities. Strengthen GBV and family planning data management systems. This is, I think, underway. There's still a need, though, to strengthen the system so that we can better understand the family planning needs of GBV survivors and how well the system is meeting those needs. As was mentioned earlier, the Ministry of Health and WHO are piloting and scaling up a national GBV database that, when I had looked at it, currently didn't collect information around family planning, so that's something that could still be addressed and improved. Fourth, form coalitions to advocate for increased budget allocations. Like we said, there's just not enough funding to implement all of the needed GBV programs. And so there is a need for kind of increased efforts to do budget advocacy. And I think one of my colleagues had also mentioned that they're advocating for a budget line specifically for GBV programs, which would be fantastic. And then finally, to expand the community-based GBV prevention programs. So there's been a number of very strong pilot programs in Uganda, like SASA. I think most people in this room are probably familiar with it. But these programs haven't been scaled up or implemented nationally. And so there's a need, if we can increase resources and then investment in this to scale up those programs, great. There's also other options, for example, looking at ways to scale it up through existing programs like the village health teams or village community program. And then, of course, there's a need to address cultural norms that condone GBV in policy dissemination efforts. I think globally this is a gap, a weakness. We don't often consider that aspect when we're focusing on disseminating policies. And there's just a real need to positively influence the attitudes and practices of those responsible for implementing policies. That's all I have.
Great, thank you. All right, can we give a big round of applause to all of our presenters? Great, so I don't know, my sort of top line takeaway from those 4 presentations is that there's really been an amazing effort undertaken in Uganda and a lot of progress made to translate this global, World Health Organization endorsed guidance on how to address gender-based violence and to turn that into meaningful policy and practice at a country level in Uganda. And at the same time, there's still so much more to do, right? The work never ends. But I want to now take the opportunity. I think we have, a little over 20 minutes to open it up for discussion. I'm sure you have questions. We're really lucky to have our colleagues from Uganda on the line, so let's take advantage of that. And we'll just open it up. Oh, we have one all the way in the back there. And we have this new wireless mic system, which is very exciting. Are there speakers back there? There is no microphone. Okay, so you might have to. Well, just so we can make sure they hear us in Uganda.
Sure. That is where my questions are for.
Okay, so that's the mic. Introduce yourself.
Oh my God, that is very high tech. Or is this just one of the prank things? Hi, my name is Naira Kalra. I'm a PhD, recently completed PhD from Johns Hopkins. I had a question for the government folks in Uganda. And I have 2 primary questions, really. One is, as you monitor the health sector's response to gender-based violence, what are the sort of key indicators you're interested in terms of, are you looking at rates of GBV, IPV? Are you looking at how many people are trained, what their attitudes are? Are you interested in seeing how many referrals are made? What are your key things that you're looking for, and what helps sort of allocate budgets towards this? The second question is, how are you monitoring harms? And that may actually, Avni, you could also, if you could give examples outside of Uganda even, how is that been monitored carefully? And, there are positive stories that come up, but what are cases where it's been monitored well so you could see if rates have increased or a perpetrator has been able to identify someone who's, reported GBV? So things like that, just so a lot around monitoring and how that's been done. Thank you.
Great, thank you. And those are excellent questions given, I think, in multiple presentations, the need for more evidence and ongoing data to use in advocacy was mentioned. So let's turn it over to Miriam and Maggie to comment on, what data you need and what indicators you're using to try and collect the evidence that you need for advocacy.
So, Miriam, the questions were, what indicators are you using to monitor? And then the second one was, what are you using to monitor? How do you monitor? And what budgets towards this?
Thank you very much.
Are you not from?
Yes. Thank you very much. I will just share a few of the indicators that we are monitoring in the health sector. And these are health-related indicators. One, we are monitoring indicators which contribute to quality of care. For instance, we are monitoring the service providers who are trained. Like we put a standard at least to have two health service providers trained per facility. So we monitor to see how many health facilities have at least two service providers trained as a proxy indicator for provision of quality services. But we also monitoring the timeliness on the side of the client. We also looking at the proportion of survivors who report within 72 hours after the incident. We are tracking that also, because if they are coming late, then it can also give us another activity to mobilize the communities more. We also monitoring the clients who come in time and get timely response, like EC, PEP, that kind of information we are tracking. But also, we have a challenge in the documenting the actual cases, like you could say physical violence, but we are using proxy indicators to monitor physical violence reported in the health facility. For instance, we are monitoring survivors who report to our facilities with injuries due to GBV. We are capturing that as an indicator in our HMIs. We also monitoring survivors who come to our facilities with depression due to GBV. We are capturing that one and we are monitoring them in our HMIs. Then
questions related to budget towards that effort.
Then for the budget, we are realizing this budget through government of Uganda budget, but also with support from partners. Partners like USAID, UNFPA, and WHO. We are getting this money in a contributory manner.
So, okay. You're pulling resources from different partners.
Yes, pulling resources from different partners. Thank you.
Great, thank you, Miriam. Maggie, did you have anything you wanted to add?
We have similar indicators, only that nationally we also look at the incidences reported at the different service points and to different service providers. And then we also have an indicator for, remember Miriam showed the slide on attitudes toward tolerance to GBV, and that level of awareness and reduced tolerance and accommodating GBV as a norm. So that is another key indicator, in addition to what Miriam has talked about, but also the number of duty bearers trained, and so on and so forth.
Okay, and if I could just ask a quick follow-up question. In terms of advocating for more local resources, for a line item in the Ugandan budget, or increased local resource allocation, what data is most compelling? Like, what data is most useful for your advocacy efforts related to resource allocation for addressing GBV? What do policymakers want to know?
So, in other words, what kind of the information would you share with the maybe the legislative, maybe the government, so that they are convinced to give you more money towards these efforts?
I think some of the data that we need is the prevalence, of course, to show the burden of the disease, the burden of the GBV incidence. But also we have to highlight the health consequences and the development consequences. It has many consequences: the health, development, and the social. We need to categorically bring out the consequences and its impact on health and development. Then I think maybe we shall raise more awareness and buy in to respond if we are to overcome those bad effects of GBV.
So,
Another set of evidence was the evidence around the economic cost of GBV. In other words, what it costs to respond to GBV across the sectors: judiciary, health, social, psychosocial, care in shelters. So the economic cost quantified was also a powerful set of evidence that helped shape the attitudes of policy makers.
Definitely, definitely. Great. Okay, I know there are other questions in the room. Jill, do you mind coming up?
On my way.
And while Jill's making her way up to the microphone, those of you that are joining us remotely, you can also ask questions by typing them into the chat box through the link that you joined. Okay, so please write in your questions if you have any. Go ahead, Jill.
Jill Gay, What Works Association. My question for all four presenters, including Avni, is what do you have in place for the health workers who provide the GBV services? What kind of self-care? It's a very stressful, taxing job. They may be experiencing gender-based violence in their own personal lives. They may be experiencing sexual harassment and abuse on the job. So what is put in place for those health workers? And I also want to ask that of Beth, who's in the room.
Okay, why don't we see Avni? Are you still with us? We can start with you.
Yes.
Yes, we are.
We are.
No, I was asking if Avni is still with us.
Yeah, can you hear me?
Yes, go ahead.
Okay, sorry, I was on mute. Maybe just I'll start with Jill's question around the self-care for providers. In the training curriculum that we are in the process of finalizing, we have included a section on self-care. So, recognizing that providers themselves are probably going to experience vicarious trauma, as well as their own issues in their personal lives that can sort of cause trauma even as they treat survivors. That we have included some exercises around self-care. We do talk a lot about in our trainings around stress management for providers, for patients, and we often in the training teach that as to providers. In the health manager's manual, there is explicit sort of guidance for managers to recognize and address the issues of provider burnout. We call it as part of provider burnout, but also as part of healthcare policy or workplace policies, there is clear guidance in the manager's manual around ensuring several things. One is sexual harassment policy needs to be in place. The other is around mechanisms for accountability for providers who might be disrespecting and abusing patients. So some sort of accountability mechanisms in place for that. And that guidance is there for countries to sort of adopt and adapt from the WHO guidance. I just wanted to also quickly respond to the earlier questions around indicators, and I think there was a question around how are harms monitored. At the moment, the data collection systems in the HMIS globally, most countries don't have very solid HMIS systems for collecting data on GBV. Uganda is an exception. So, you know, harms can only be monitored if you have accountability mechanisms in place from patients, so patient feedback, as well as working with NGOs to make sure that any unintended consequences are being addressed, and some of that work hasn't really happened. So I think that's an area or a gap. I think also maybe to say that the indicators, one is as a proxy for quality is also to see if over time in that facility GBV cases are going up, which is a bit counterintuitive for a lot of people, but the fact is that if providers are doing their jobs right, and if they are trained, they should be able to over time identify more cases. And conversely, if they are getting if patients are getting good quality services, usually that should also filter down into the community in terms of you know, more people coming up. So with that in mind, in India, we have an implementation research study that's going on in 3 hospitals, where we are triangulating the provider reports of what they have done with facility register data that looks at reports of GBV cases over time, but also what kind of care was provided. So, you know, did they provide first-line support? Did they provide referrals? Did they provide the usual clinical pieces? Did they provide basic psychosocial support, including mental health care, referrals, etc.? And we're tracking those to see how these things are improving over time. And if this works as a pilot, then we will be in a position to kind of recommend this set of indicators as minimum set of indicators for tracking in health facilities, because we are also mindful that we don't want too many indicators, but the HMIS system form that we've developed is just a one-page form, with the idea that, you know, a nurse or a social worker can probably fill out most of those fields.
Thank you, Avni. I know Beth wants to add something to the most recent question about self-care.
Yeah. So just to respond to that, so as Avni said, in the policy document, there are materials and resources around that. We didn't find anything in our interviews around a formal structure or really any mention of how providers are managing self-care. We also didn't ask explicitly about that, so that could be the reason. There was some mention in our interviews of how because the training provided the health providers with more confidence, they were beginning to mentor their other colleagues on provision of GBV services, which is different than self-care, but also shows that they are starting to do more mentorship and support to each other. So,
great, thank you. I'm actually going to move on to the next question, which came in from one of our remote participants, and I think is a good question for our Ugandan colleagues. Do you mind reading the question?
Yes, Diana.
Just make sure they can.
Diana Aranco asked, I understand that Parliament recently rejected a $40 million loan that was poised to support work to prevent and respond to GBV in Uganda, with significant resources for the health sector. Are there any lessons from this failure in resource mobilization?
Marianne and Maggie, did you hear the question?
Come again? Oh, was it a rejection by the government?
Okay, I'm gonna read it one more time. So a participant that's joined us remotely wrote in with this question. I understand that Parliament recently rejected a $40 million loan that was poised to support work to prevent and respond to GBV in Uganda with significant resources for the health sector. Are there any lessons from this failure in resource mobilization?
Which you heard.
Yeah, we're aware about the project, but we're not aware about the status of that and whether really the parliament has rejected, because to the best of our knowledge, it's still being considered by a parliamentary committee on which approves the loans. So we are not aware. This was in reference to a World Bank loan.
Okay.
So we're not positioned to answer, yeah, because we don't have the facts now.
Okay, well, fingers crossed then that it's approved. Great, I do have, okay, there are a couple more questions in the room, and I have another one that's come in remotely. So I think probably these will be our last 3 questions. Let's start with Juliana.
And can I take 2 questions?
Yes.
Okay, thank you. Okay. So first question is actually for Beth, and I wanted to see if you explored or looked at provision of HIV post-exposure prophylaxis, and if so, what the findings were. That's the first question. And the second is actually for Maggie and Mariam. And so I know that the WHO global guidance is focused on intimate partner violence and sexual violence, but some countries also focus on other forms of violence, like FGM, for example. So I was wondering, in your local guidance, were there any adaptations to address other forms of gender-based violence that are relevant to Uganda?
Thank you. Good questions. Beth, you want to go first?
Sure. So we did not look specifically at post-exposure prophylaxis, just in the context of kind of the broad post-GBV care services that they were providing. Most health providers knew about the medicine, knew about the time frame, which I think actually might be part of the confusion of the EC and PEP, since they have different time frames now, perhaps, and there were issues of stockouts with that as well. So that's about all that we uncovered with that.
Great, thank you. And Miriam or Maggie, can one of you respond to Juliana's questions about whether your local guidelines were adapted to address other forms of violence beyond sexual and gender-based violence that might be relevant in Uganda?
Actually, the guidelines that we are using currently, they are focusing more on sexual violence other than the other types of violence. Reason being that other forms, especially physical, is covered somewhere else in other documents. But this year round, in Uganda, we have 2% of the population that practice FGM, but in their 6 districts where it is practiced, it is almost 90%, over 90%. So this year we are going to adopt the WHO guidance and adopt the management and response for FGM survivors.
For female genital mutilation.
Yes, we are considering that, and we are hopeful that by the end of this year, with the support from UNFPA, we shall have country guidelines. However, we have been having projects and the NGOs that have been specifically sensitizing the communities and responding to FGM survivors.
Great.
So basically, the broader perspective, they are using sexual violence guidelines, but sorry?
Health.
And in the health sector. So I think the team members.
Maggie, can add on?
Yeah, the different sectors, as I had said in my presentation, the different sectors have have develop their own different tools and guidelines. So for the health sector, that's what's happening. But for example, the tool for training under police, the best I know is generally about domestic violence, because they do have a child and family protection unit. So they it moves, the focus is along where the legal framework is, which is on domestic violence and violence against children. And ours, as Minister of Gender, Labor and Social Development, ours is general. We talk about domestic violence, violence against children, violence against women, and that's why we use the broader terminology of gender-based violence.
Great, thank you. Okay, we have another question in the room, and introduce yourself, please.
Hello, my name is Ashley Howard. I'm a technical advisor on violence for CBC. I wanted to go back to the challenge that Maggie noted on referrals and the challenge in implementing those. So wondering, as much as we're trying to get survivors to disclose and report violence, how do we make sure that they have adequate access to all the follow-up services, including health and justice, legal, police services, and if you had as much money as you needed, what would you do to strengthen those linkages and referral pathways? Thank you.
Great question.
Did you hear?
Maggie, or
Did you hear the question?
I didn't hear very well. I didn't get that very well.
oh, you didn't get
Oh,
So I'll just quickly summarize. If you had all the money in the world, how would you strengthen linkages in referral pathways, especially between health and justice for survivors of violence?
okay. How do you strengthen linkage between the health and what is the other one?
Get it?
And just
Let me try. I hope I've understood carefully or properly.
if you had all the money, how would you strengthen that link between justice and the health?
Maybe one of the gaps that we have noticed is the evidence from the investigations going to inform the health sector and also the tools that are needed. So I think if we had the money, adequate money, we would strengthen both those areas for collecting evidence against the perpetrators, to bring them to justice, and then also assisting the survivors of GBV to heal both medically and psychosocially.
And in addition,
I don't know if that's...
what we know is that in the package, for example, in the health sector,
yes,
for helping this person, the victim, the GBV victim, is that part of the package is the linking them to the justice.
Legal services.
Legal services.
Yeah. Affordability of legal services is also another.
So it's a requirement that the health worker attending to this GBV victim ensures that in addition to the treatment provided, it links the patient to the legal services. Yeah.
Can I come in?
Yes, go for it.
Yes.
Hi. No, I think I wanted to make a larger point about the improving referral services. I think what evidence we have from in fact even from the US is that the assumption that women want a lot of referrals, because this idea of identify and refer comes from a lot of US-based trials on screening, which most of them have shown absolutely zero effect. And the reason is the assumption that women want referrals without recognizing the opportunity costs that it means for women. If one looks at the trials done in Illinois and other settings, is that for women to actually run around and get different services, it's not easy. They have childcare, transportation. Most women who are in abusive relationships are also controlled, which means getting out of the house and leaving the house is not easy. And so the evidence actually kind of is contrary to the assumptions that identify and refer is what women want. Most women want somebody who listens, who believes, who actually validates their experience, and who gives them the care that they need in terms of the psychological support. So I just think that, we need to also, if we want to be evidence-based, then we actually need to see what women really want from these services and put money and investments in those spaces. If we don't make sure that whether it's the police, whether it's the health workers, whether it's the social services, whichever point women are accessing services, they are getting a modicum, a minimum of, a trained provider who believes them, who listens to them, who gives them that psychosocial support, then simply putting money in it, identify and refer is really not what women want. Most women will tell you that in most of the studies.
Wow.
Actually, if I can have an input.
Sure.
When we were starting to strengthen GBV services, we had in mind a one-stop center where maybe a victim, a survivor would come and get all the services needed. But when we evaluated the cost of a one-stop center, we couldn't afford. So we ended up having what we call safety shelters for temporary. That these are temporary shelters where women who are threatened with unsafe situation is at home can be kept for a short time. Meanwhile, they relocate where they can go. So we have it in our mind. So like it was said earlier, if you have all the money you need, we can have model we can have model one-stop centers for GBV.
Great, thank you. So,
hello?
Hi, Dr. Did you want to add something?
I mean, I like the idea that we need to listen to the clients, the ones who are affected. What do they want? And I think that's a very good principle in quality improvement, that we do sometimes come up with the interventions that might not be suiting the clients. So it's important. I think that is one area maybe the team could do consider in future.
Although I'd like to add that we also have seen from discussions with the justice, law, and order sector in our country that if we the perpetrators are not brought to book, if justice is not, if the cases are not pursued, evidence brought by the police and the criminal justice system, for example, for sexual violence cases, then it leads to impunity. People think that you can continue to get away with these cases. So it's still equally important to invest in the justice system to make sure that perpetrators are brought to book.
Great, thank you. We have one last, it's really a quick clarifying question that came in from one of our remote participants that I just want to make sure we address. For the Ugandan colleagues, one of you mentioned that there was this challenge of rotation, and they're just wondering what that means. Is it the challenge of facility staff retention and sort of consistently training new staff that come on board? Is that what you mean by the challenge of rotation?
Oh, let me.
This occurs, we have a challenge, a general challenge that in most of the institutions, GBV was not covered in the pre-service. So as a way of strengthening the service, we are training in-service staff. Then you go and train people from a particular area, and when you go for follow-up, they have changed them from that particular facility to another one. This is contributed to by the fact that we don't have enough resources to train everybody at that facility. They can pick, for instance, 2 or 3 from that facility. to ensure that at least there are some who also who can respond effectively. But when you go back, you find they have been changed from that particular facility where they were trained and taken to another one. When you look at it from the other side, you will be contented that they are still offering a service, but it will affect your project evaluation.
Yes, maybe in addition, here the tendency is by the district leadership that's in the health sector to, as a part of part of the punishment to the people, the health workers who are not doing what they are supposed to do, is to transfer them as a punishment. And in doing that, like Miria has said, that one would think, would expect that maybe when he's transferred to some other place, then he would be able to bring on board these other members whom he has found at site. But remember, there are a number of issues that you would need to consider to accredit a site for providing GBV. So this person will remain with his knowledge, but not able to start a service at that point. But there are sometimes we've tried to talk to the district leadership to consider if a person who has been trained to hold him for some time and be able to pass this information to the others before that comes as their last resort to transfer.
Great. Thank you so much. So I'm sure there are other questions, but we do need to wrap this session up and bring it to a close. Thank you all for your very thoughtful questions. And Beth, Agni, Maggie, and Miriam, thank you so much for your really rich presentations and for sharing with us this story, this case study from Uganda, which I hope can serve as a model for other countries that are working and have the political will and commitment to really meaningfully address gender-based violence in their countries. So especially Miriam and Maggie, I know it's starting to get late your time. Thank you for joining us. I want to give everyone another round of applause.